أمير رشيدي أستاذ الدكتورة حنان إبراهيم. هو 7-year-old male patient, third order of birth, non-consanguineous parents, known case of post-climacteric CP with past history of NICU admission with jaundice. Condition started at the age of 5 months with abnormal movement in the hand in the form of dystonia that later progressed to involve the whole body in attacks with no loss of consciousness or cyanosis and disappeared during sleep. The attacks become frequent and interfering with daily activity associated with pain and cry. The patient sought medical advice and started to receive the anticonvulsant in the form of tiratam. Also, he received baclofen, Tenamant, gabapentin, dipakine, with reaching to the maximum level of the anticonvulsant. Unfortunately, the patient did not improve, so tiratam and levodopa and gabapentin were withdrawn and stopped, but still the patients have the frequent attack of dystonia. So the decision was taken to insert an intrathecal baclofen pump about 2 years ago. The condition started to improve and was controlled for 6 months, but still the patient presented to our PQ with another attack of involuntary muscle contraction and twisting movement. On examination, the patient was agitated, crying with arching and torticollis. He had marked hypertonia, hyperreflexia, and spasticity. So we put him on the dystonia severity scale. We found that he is on grade 2 or grade 3, which was that he cannot tolerate lying with sleep disturbance and no signs of metabolic like fever, dehydration, or airway compromise. So we start to do a metabolic screen looking for any signs of decompensation. His CK total was the 937, his ABG was the pH 7.3 and CO2 40 and bicarb was 24. So he was not in decompensation. So we do an urgent assessment for any trigger factors that may exacerbate his attacks. We found that he had constipation, so we started to treat. Medication adjustment and escalation of the doses were started, so oral clonidine was started and baclofen we increased the dose to the maximum. Also chloral hydrates was added and parkinol. We started to give midazolam shots to improve the condition, but we couldn't reach to the baseline, so midazolam infusion was started and the condition started to control for 48 hours. So we did a neurological consultation to look for any obstruction or migration of the intrathecal baclofen pump catheter. So we did a CT whole spine and we found that the catheter mostly migrated from the original side. So the decision was to enter into the neurosurgery department to reposit the kinked pump. And the patient was controlled on the midazolam infusion and we tapered it to stop and the patient was discharged from the ICU. Finally, I would like to thank all my staff and dear colleagues in the ICU for their great support and thank you. واشكر طبعا الدكتوره امنيه كانت بتشاركنا في الحاله على طول وبتساعدنا في ان احنا يعني نحاول نوصل للعيان ان هو يكون كنترول.